Good afternoon, everyone. My name is Dr. Rosalind Kinuthia. I am head of Unit Infection Prevention and Control, Kenyatta National Hospital, and I'll be your moderator for today. So our session today is on infection prevention and control practices in promoting patient and staff safety. One of the reasons we decided to have this webinar is because we are celebrating or commemorating the International Infection Prevention Week, which runs from the 17th to 23rd October. And the theme for this year is Make Your Intention Infection Prevention. So the key aim for this for commemorating this week really is to highlight the key role that IPC practices play in patient safety and clinical outcomes. And today we have two presentations from our healthcare quality division, which deals with the patient safety and healthcare quality. So we'll have a presentation from one of our patient safety officers, and then a presentation from the infection prevention and control unit. Then we have our panelists with us. We have Dr. Lydia Oktoye as one of our panelists. She's the director, healthcare quality. And then we have Dr. Duncan Nyukuri, who is an infectious disease specialist and is practicing in our IDU infectious disease unit at Bagathi. So welcome again, and without taking much time, I think we'll just go into the presentations. So we will hold a question and answer session at the end, where we will engage our panelists to take your questions as they come. So please keep putting your questions in the Q&A, and we will handle them at the end of this. So I want to invite our first presenter for today, and this is Ms. Charity Kiaji. She is one of our patient safety officers in the healthcare quality division, and she's going to take us through patient safety aspects in infection prevention and control. So karibu sana Charity.
Thank you so much. Good afternoon, participants. My name is Kianji Charity from Patient Safety, Healthcare Quality Division. I hope you can see my slides.
Yes, please go on, Charity.
Yeah, and I'm going to take you through the section of patient safety aspects in infection prevention and control. Generally, I'm going to start with the introduction. I'll do a bit of definitions. From there, I'll look at patient safety goals. Then I'll look at the way forward and a bit of explanations on how the safety incidents occur. So we have an introduction whereby 1 out of 25 patients hospitalized are affected by hospital-acquired infections. And this is associated with increased mortality. So we lose a lot of patients on this, and it's also attributed to costs that lead to billions of shillings. So we also have 2 out of 10 patients who come to the hospital being affected by medical errors or having interaction with unsafe care. So this makes us recognize the significant burden of avoidance harm to patients. So I'll start by saying that hospitals are generally safe, but some harmful events happen that affect patients. Unfortunately, many of these events are preventable. So that means there's something we can do about it. Now, let me define what patient safety is. And I'll start by saying it's prevention of errors and adverse effects to patients. That's a WHO definition. It's also an important aspect of what we call healthcare quality. We also move to what we call medical errors. It's important. We also define it, which is defined as an act of commission or omission leading to undesirable outcome. And this has a significant potential for such outcomes. Let me give an example of a commission and omission. At times, we have our patients coming in, maybe to our A&E, and once they come, like a patient may present with a pneumonia, and we give them antibiotics. They have difficulty in breathing, they go home. Once they go there, they're not getting better, they come back. And when they come back, we do further investigations and realize this patient not only have a pneumonia, but this patient could be having a pulmonary embolism. So we start the treatment again and give, let's say, anticoagulants. So in this case, we have a commission, we treated the patients, but the outcomes were not what we expected. We also had an omission, which was left out. Patient was not treated for the Ebola. So this one becomes a medical error, which is a reportable event and which is regrettable. This is due to the complexity of the system. So let's look at the other medical error definition according to IOM. These are mistakes made in the process of care that will result in or have the potential to result in harm to patients. We also have a definition of adverse events. These are injuries or harm that results from medical care, and they're generally categorized as preventable and non-preventable events. So let's look at the next slide. What are the patient's safety goals? According to the Joint Commission of National Patient Safety Goals, the first goal, we have what we call identification of patients correctly. That means that every patient coming to our hospitals to be treated needs to be identified correctly using 3 names, using an identification card, or we can use a name tag to make sure that the patient is correctly identified throughout care until discharge. Now we have the goal number 2, which is improve staff communication, or what we call effective communication. We have safety gaps because of communication. Actually, it's a big issue whereby we need to use the SBAS, that is situational background assessment and recommendation when you're communicating. We'll not go deep into that because I have like 15 minutes, but we need to look at that. We also have team steps whereby every person involved in care needs to have information of that patient they're taking care of as the patient interacts with them, and communication of what is happening is clearly stated. We have improvement. We need to also improve the safety of high alert medications. This is the anti-safety, patient safety goal. And this is where we work with other departments like the pharmacy to report the lookalike drugs. We also need to store the drugs well. We also need to report any side effects that come to our patients so that we ensure that the right drugs are administered, they are stored well, and they have minimal effects or side effects for our patients. We also need to ensure safe surgery by doing what? Preventing mistakes in surgery. How do we do this? By implementing the WHO checklist, which is a must for every patient who is going through for surgery. And this helps the teams involved check, counter check, and ensure compliance. That is the nurses, the surgeons, the anesthetists, the receiving nurses, and the primary nurses. We have the 5th, that is reduce the risk of healthcare associated infections, and that's the goal number 7. I've not put up every goal, which is the infection prevention, and that's why we are going to dwell on today. We have several guidelines that need to be followed to make sure that patients walk in safe and live safe without carrying the nosocomials or spreading them out. We also need to reduce the risk of patient harm resulting from falls by identifying patients at risk who are within our hospitals, confused patients, patients who are using medications that can cause the side effects and cause them expose them to faults. So we need to identify them early and either change the medication or ensure safe environments. We have other goals that follow here, like medication safety, equipment safety, and the other two, but I will not go there today. I'll end it there. So let me look at the reportable patient safety events, and these are in our work instructions that have been formed by our patient team, Dr. Kalondo and Dr. Kitoi. They've done a great work in giving us the work instructions. So we look at the never events, and these are events that must be reported within the 24 hours of occurrence to the HOD or the relevant bodies for action and prevention from the occurrence. The examples include wrong site surgeries. Any surgery that has happened within the healthcare system that was not intended surgery, wrong patient, wrong site should be reported to the patient safety and to the administrative consent. Wrong patient blood transfusion should also be reported because we have policies, procedures that should be followed to avoid this from happening. We have counter checking of 2 nurses, we have screening, so many policies and do's and don'ts have been put up. Medication errors can also be reported, never events, because drugs are also supposed to be counter checked. We also have more than 4 people on the line. We have the prescriber, we have the pharmacist, we have the nurses, we even have the patients who can counter check what is happening. So they are never events. Then certain hospital-acquired conditions also need to be reported. And these include central line associated bloodstream infections. We have surgical site infections. We have ventilator associated pneumonias and other resistant bugs within the hospital. So this is an example of a cheese model of accidents. I like using it to describe and show the successive layer that the hospitals or the system has put in place. But at times we have hazards penetrating and causing accidents. So under this cheese model or the cheese, we have some O's due to active failures that occur. Others are due to what we call latent conditions. And in a normal situation where policies, procedures are in place, we are supposed to divert off the hazards from the first barrier. If you can see the second diagram, it's showing a diversion of the hazard out so that it doesn't reach the patients. So if it's a patient going to theater, for example, we have the first checklist being checked, first identification. We have another barrier where you do the checklist. We have different people reviewing the patients. We have the patient going to theater, they counter check again, they mark the site. So all these are policies and barriers to stop the hazards from reaching the patients. So generally that is it for that. It's a drawing to show how errors penetrate and reach the patients as we take care of them. Now we have another diagram that represents the culture of safety or what we do, what we practice. And the first one shows culture of safety, how we do things, just culture, like in infection control. What do we do when we are alone? Are we forced to, let's say, clean our hands? Do we report these medical errors or safety incidents when they occur? Is it a voluntary system? As an individual, how is our behavior? Do we sanitize our hands before we move to the next patient? Do we only do it when somebody's looking at us? So this collective behavior also goes to what we call organization performance. Are these facilities available? If I want to sanitize, are they there? Do we have the structures in place to help me keep the patient safe? And when all these things fail, the outcomes, like in infection control, we'll see either there will be improvements or bad outcomes. So we can have good and bad outcomes depending on the culture of how we do things. So what's the way forward? So most of the hospital-acquired infections are preventable. That's the first thing we need to know. So what do? We need to do surveillance for hospital-acquired infections, using trends for informed actions. By that, we can strengthen the IPC by doing hand hygiene practices. We can do advocacy for IPC. We can also do audits of the system to check where we are. Once we get the reports, we can give feedbacks. We can also look at the infrastructure and the system controls. How well are we doing? Do we have systems in place that are working? Next is engage patients. At times we forget our patients. We need to involve them in the prevention of infections. Patients need also to clean their hands. They need to obey the guidelines that are put in place. They also need to understand why we are doing certain things to them. We also need to learn from the health systems, and learning is continuous. Once errors or we have lapses in the system, we learn from them. And there's another one we call culture of safety. Very important, how things are done, how we learn, how we improve the system to avoid the recurrence. So we also need to implement the care bundles for CALTI, CLAPSI, VAPS, and surgical site infections. And the care bundles can include, but not limited to, taking care of patients who have been going for surgery, giving them, ensuring their sugars are right, ensuring they've bathed, avoid shaving, giving antibiotics that have been prescribed for prophylaxis, as the care bundles, as guidelines direct. So last but not least, we need to monitor and respond to reportable events. These reportable events are many in medical. In patient safety, we have a variety, as I mentioned earlier. As I mentioned earlier, in the patient goals, we have many sections that we need to report, and these include MDROs, that is multi-drug resistant bugs that happen. So that is it for now. My intention is infection prevention. Act now for safe care. Thank you. I'm open for the questions.
Wow, thank you very much. Thank you very much, Charity, for a very good summary on patient safety goals and reminding us to, inculcate a culture of patient safety. And again, reminding us where we were, where we started when I mentioned that this is the Infection Prevention and Control Week. And the theme is make your intention infection prevention. So it all has to do with what we do and what we choose to do and what we choose to inculcate as our culture and as our practice. And again, she has reminded us that apart from individual behavior, there is collective behavior. And most of the times when it comes to infections, what you do will not just affect you, but affect others around you. And ideally, we should not have anyone contracting infections when they are receiving care. But when these things happen, we need to, follow through, report what is reportable. So I think with that, we'll move on to the IPC team. We've been given a very good background on how IPC fits into patient safety. So we'll have Celestine Jaimbo and Christopher Kibiwot take us through the next session on infection prevention and control practices that help us to promote patient and staff safety. So it's not just about the patient safety, but also staff safety is key. Without much ado, I welcome Celestine to continue.
Thank you so much, Dr. Kirumpia. Our next presentation is on infection prevention and control practices in promoting staff and patient safety. So we are not just interested in taking care of staff, but we are also interested in taking care of patients or vice versa. So hospitals generally expose patients to inherent risk. The risk could be obvious or not obvious at all. And as much as it exposes patients, it also exposes healthcare workers to the same risks. So both groups must always be protected against this risk. So we are not overlooking any group. We are saying both of us needs to be protected against this risk. And to oversee this, the hospital should have a vibrant infection prevention and control protocols. So generally, infection prevention and control practices are a cornerstone of any, cornerstone in prevention of transmission of infections, both in the hospital and in the community. We've had people getting sick in the community because of our careless practices that are endangering them. So we are focusing, as much as we are focusing on hospital-acquired infection, we are also taking care of the community. And infection prevention and control comprises a set of practices. These practices are referred to as standard precautions. So just as Charity has said, the patient safety goal number 5 is basically focused on reduction of healthcare-associated infections or healthcare-acquired infections, mostly known as HAI. IPC is a practical evidence-based approach to this, to prevent patients and healthcare workers from harm by avoidable infections. And generally, the overall contribution to IPC is to patient safety and good clinical outcomes. We want the patient to be safe, we want the healthcare worker to be safe, and in the long run, the clinical outcome must be very good. So there are 10 ways to protect the patient and staff. And as you see in my diagram, the 10 ways are summarized in a pictorial. First is about hand hygiene. Second is staying home if you're sick. Basically, not literally, but you need to be seen and be given permission to stay at home. Then know if antibiotics are appropriate, and we call it antimicrobial stewardship. We are following guidelines in that stop. Follow all posted precautions. This include the guidelines, include the protocols, include the standard operating procedures. We are using personal protective equipment, and personal protective equipment generally are to protect us and to protect the patients against the harm that we are talking about. We are talking about vaccination, again, for both the healthcare workers and the patients. Safe injection practices must also be adhered to. We are talking about environmental sanitation. We are talking about health education, both to the patients and to the healthcare workers. So the next, we are going to start basically with hand hygiene. So we have to perform hand hygiene, emphasizing on the 5 moments of hand hygiene. We are emphasizing on technique, we are emphasizing on how long you're taking, and we are focusing on when to know what to use. Can I use a sanitizer here? Can I use soap and water? So basically, it is cleaning the hands by the use of soap and running water or alcohol-based hand rub, basically known as sanitizer. So when you're talking about the moments of hand hygiene, which we preach every other time, the first moment is basically always before touching the patient. We always tend to neglect this because we always think that it is the patient who has microorganisms to transmit to us. But as healthcare workers also, you could be having some microorganisms in your hands that you could transmit to this patient. So you need to wash your hands before touching the patient. Before clean or aseptic procedure, you need to wash your hands or sanitize your hands. When you are at risk or after body fluid exposure risk, you need to touch your hand. You have emptied a urine bag. You have handled blood, maybe in the process of care, it may be inserting a granula. You've handled IV fluids. Please sanitize or wash your hands. Then generally it comes after touching a patient, wash your hands, and after touching a patient's surrounding. This is again another one that is always forgotten, because any part of the patient surrounding could be a risk. Any part of the surrounding hospital could be a risk. So when you touch it, either you are introducing microorganism to it, or you are getting microorganism from it. So it is important to wash your hands. And patient environment, we are talking about maybe the patient lockers, the bed, the side rail, the monitors, the ventilators, all that need to sanitize your hands. All that are in the patient surrounding. So with the 5 moments, then are we also doing it the right way, the right technique? So if you look at the slide there, it is showing you how you're supposed to wash your hands, the technique in which you're supposed to use. First of all, you're supposed to wet your hands with water, then apply enough soap to cover. Then the next one is rub hands palm to palm, then right palm over the left dorsum and left palm over the right dorsum. Then you repeat the other way. Then in between the fingers interlace, the knuckles, the thumb, the depression in between the hand and the wrist. If you have a ring, you're supposed to, a wedding band, you're supposed to hold it and move it around so that the area under it is also sanitized or is also washed. Then you clean your hands. If you are using soap and water, you dry it and you throw the whatever it is that you have used. You have seen that this, according to my diagram, this thing is in several steps, but we preach that know which area you're supposed to cover, so that we are not having you standing somewhere waiting for instructions and waiting for a diagram. If you know that in the first instance, I'm supposed to start with palm to palm, and the last instance I'm supposed to be using, I'm supposed to be at the wrist. So if you cover all the areas, you are safe. You have done the technique well. Can we continue? So the next one we are talking about is staff health. So just the way we are interested in patient, we're also interested in staff. And even as the staff are observing this is also supposed to be observed by the patients. And we are saying, observe the standard precautions. And that is what I am highlighting on. We are encouraging personal hygiene. Be somebody who is clean, who is neat. That is both the healthcare worker and the patient. Be vaccinated. Vaccination is going to help a lot, as by the next person will also talk about it. And we are encouraging all the healthcare givers and the healthcare recipients to be vaccinated. Periodical screening and redeployment. Where somebody has stayed for some time and the person is feeling they are more at risk and they are more exposed, then they could be screened. And we also talk about redeployment. Useful exercises in maintaining of our health. Do useful exercises. And above all, we are talking about mental health. We are not taking it for granted that we need to be stable mentally, psychologically. So this is another area that really should be taken care of. So Kibiwot will take over from here.
Thank you, Jaibo. So the next, first of all, my name is Christopher Kibiwot from IPC, and I'm going to continue as part of the standard precautions by handling what we call antimicrobial stewardship. You realize that there is a lot of empirical prescription of antibiotics in many healthcare settings. Right, when you go to medical wards now, the only drug which is being prescribed is, you'll find that it is just one. So what IPC advocates is basically what we call evidence-based antibiotic use. Before you prescribe that antibiotic, it should have some basis that you have done a blood culture, you have done a pulse swab, so that you'll be able to give that patient an antibiotic, which is necessary. That one reduces the cost and also reduces the possibilities of complications associated with giving a lot of drugs to a patient. For us to achieve that antimicrobial stewardship, there is what we call laboratory surveillance, which is a very useful tool these days when it comes to management of IPCs all over the world. And we are trying so hard to make sure that it is inculcated in our health facilities. It is a useful tool for IPC operations to track hospital-acquired infection. You will never be able to know the trend of a certain microorganism if you have not done any surveillance. You'll never be able to know whether we have multi-drug resistant organisms. You'll never know whether we have emerging bugs if we don't do surveillance. That is why surveillance has come to be a very important aspect of IPC practices world over, and we are trying to do it in our hospitals, especially in KNH. So these are close and a cheaper way of ascertaining presence of hospital-acquired infection. That is the laboratory surveillance. By you going to the laboratory, getting those results, it can be able to tell you, to gauge how far are we in terms of hospital-acquired infection. At least it is a good indicator. Maybe we need to do a closer look into it, but surveillance can play a very big role in ascertaining how deep we are in hospital-acquired infection. Laboratory surveillance can also inform on antimicrobial stewardship, and that is linked to point number one that I said: prescribe drugs based on some evidence that you have a certain bug you are trying to treat. We have seen many situations whereby a patient is given an expensive drug like Meronem, yet there is resistance to that bug, to that drug by the bug in question. So that one enables us to give the patient the correct antibiotic, minimizing the cost, and at the same time making sure that we treat the correct microorganism, and that helps in the long run by fighting the resistance, which has been happening all over the world. Then we have another aspect of standard precaution, which helps in patient and staff safety. That is policies and guidelines. Without policies, without correct guidelines, everybody will be doing what they feel is right for them. So establishment of policies and strategies provide a framework. Policies and strategies are actually framework, so that if you are sent to a certain hospital in Lodwar, you'll be able to know this is what I'm supposed to do according to the Ministry of Health policy, according to the local policy. And policies are actually, we have the national policies, which covers all the hospitals in the country. Then we have the localized policies, which differ from one hospital to the other, but the technical aspect remains like that one of the national. We also have the standard operating procedures. Like the other day, I think Dr. Nyukuri will be able to share with us the latest COVID-19 SOP, which was developed after the previous one. So that those procedures are supposed to be followed to ensure that the staff and patient are all safe when it comes to hospital setup and even in the community. This will help establish a culture of safety in healthcare facilities. And my previous colleague has actually talked about why it is important to have patient safety in our healthcare settings. Well, so we have the national and the facility guidelines, which are available. KNH has several facility guidelines, and I am sure many other hospitals have their own guidelines, but we always follow the national guidelines. As we follow policies, guidelines, and SOPs, we also have posters posted on patient doors, posted in theaters. When you see a red line as a healthcare worker, you should be able to know that that one must be communicating something. And the patients also should be educated that way, plus our relatives, so that when they see a sign written stop or do not eat, they should be able to know what that sign means, because it is communicating something. So when you talk of policies and guidelines, that is what we mean when it comes to IPC. Then we have another aspect of standard precaution, which is appropriate use of personal protective equipment. What is a PPE? The definition according to OSHA is it's a specialized clothing or equipment worn for protection against infectious material. And selection of PPE is guided by risk assessment. That is very important. Always consider the risk before you decide which PPE to use. During the COVID era last year, people are putting on all sorts of garments, yet it was droplet infection. So that was because there was irrational use of personal protective equipment, mostly guided by a lot of fear. So factors influencing PPE selection include the type of exposure anticipated. If you expect splash or sprays, make sure that you have a mask if the risk is actually of respiratory nature. If it is splash towards your clothing, make sure you have a simple garment like an apron, a plastic apron, or a water-resistant apron. Then if it is touch, make sure you have gloves, because gloves are the only guards against any touch microorganism. Then category of isolation precaution. There are also what we call additional PPEs. This one applies now when you go to an isolation facility like the infectious disease unit. There are certain types of PPE which you are supposed to put on before you get in there. All of them are also always based on the type of risk to be expected. Then another factor influencing the PPE selection is the duration of expected exposure. How long is it possible that you will be exposed to this microorganism or to this pathogen? That is also another guide. If it is for a short time, you don't need to put on a very heavy kind of PPE, look for a light one. If it is real serious case scenario, like in cases of Ebola, now that one you need to put on, you have to go all the way to make sure that you protect yourself. Another factor you need to check is the fit. It is always important that you put on the PPE which correctly fits you, because of two reasons. A PPE which does not fit you will make you very uncomfortable, and a PPE which does not fit you may tear during the process of your caregiving and expose you to a lot of risks. So those are the factors that influence PPE selection. And maybe I can talk briefly about the PPE which is very rampant these days, the mask. The mask is actually the only PPE that can protect you from COVID-19. And there are questions of people wearing two masks, which is not appropriate. When you have a surgical mask or an N95 mask, either of them can do, because they provide the same level of protection on droplet infections. The preferred in most situations is actually the surgical mask, because of its ability to be disposed. They are cheap, and you can have about 3 per day, but you cannot have the same when it comes to the N95 mask. That's why you find people who have been given an N95 mask will stay with it for a whole week. That one exposes the wearer to a lot of pathogens. Then we have another important aspect of standard precaution, which is vaccination. Jaimbo had briefly talked about it. And vaccination is simple, safe, and effective way of protecting against harmful diseases. Since childhood, all of us must have come across so many vaccines. Many of us have a lot of vaccines in our systems, and they are protecting us very well. That is why when you compare the mortality cases in this century and maybe in the 17th century, there is a great improvement. It uses the body's natural defenses to build resistance to specific infections and makes your immune system stronger. That is actually basically what vaccines does to our bodies. Then the latest vaccine to be in our midst is the COVID-19 vaccine, of course. We have several of them, and there's a rollout. I think we have had about 4 in Kenya or 3 in Kenya. And the reception is relatively good, although the level of vaccination is still low in our country compared to the developed world. So maybe Dr. Nyukuri might be able to delve more into the COVID-19 vaccine. We should always remember that this is patient and staff safety, and patients equally need the vaccination. So before during your normal health education, always ask your patients whether they have gotten the vaccination, be it of COVID or be it of the disease of concern. If you are in the liver clinic, you should be able to ask them whether they have been vaccinated against hepatitis B. There are many other vaccinations which are very important when you are discussing issues with your patient. Then we have the safe injection safety. Then this one, we cannot be overemphasized. Bloodstream infection affect patients in our health systems. And to protect against this, safe injection safety is very, very, very important. And it is as simple as preparing the injection site using aseptic technique before administering that injection or before inserting that line. Disinfect the rubber septum with alcohol. So how many of us do that? When you want to withdraw some antibiotic, how many of us do the disinfection of the rubber septum before withdrawing the antibiotic which is inside the vial? I'm sure it's very few. If possible, use single dose vials for parenteral medication. We don't want to use these multi-dose vials. Then if you must use multi-dose vials, get one vial and dedicate it to one particular patient so that we don't share. You go to areas like the new nurseries or the newborn units, you see one particular antibiotic has been dissolved and it is being used across the whole nursery. That is not a good practice when it comes to injection safety. Then before you go to the injection, shouldn't we look at other options of oral medication? So before we expose the patient to bloodstream infection, let us explore the oral before we go that far. Then we have what we call environmental safety. That is still part of staff and patient safety. Nobody would want to work in an environment which is dirty. So routine cleaning is necessary to maintain a standard of cleanliness in every operation area. In this era of COVID-19, actually the frequency of cleaning has been increased. Although somebody can say that according to CDC and other researchers, COVID-19 does not pose a lot of danger when it is on the surfaces, but we still have to maintain the high frequency of cleaning of surfaces. Then cleaning products should be selected based on their use, efficacy, safety, and cost. From time immemorial, many hospitals actually have been using sodium hypochlorite, that is the JIC. And nobody has done any surveillance to see whether it is still effective or we need to change. So always we should use a particular decontaminant or a particular product based on its efficiency, efficacy, safety, and also we have to look at the cost. Cleaning is required prior to any disinfection process. Many people do both cleaning and disinfection at the same time, or sometimes they start with the disinfection process. So the usual thing which you must do is you clean the floor with the soap and water, then come with a disinfectant as a finishing process. That will maintain that surface to be free from microorganisms for some time until the next cleaning is done. So these are a diagram which is showing how we do our environmental cleaning, and you can see these are the high touch areas actually. The switches are rarely cleaned. You can see it is 20%. We have the lockers, patient lockers, cleaned 70%. That is, I think, the highest. We have the bed rails, which we touch most of the time, 60%. We have the telephone heads, which are rarely cleaned. And when we talk of the telephone heads, we also talk about our mobile phones. How often do you decontaminate your mobile phone? Very rarely. And actually, that is a very big source of self-contamination. You go attend to a patient and you are back to your pocket getting your phone again. And it could be a source of infection for you, the caregiver, and also for the patient. Then there is another place which is also very poorly cleaned, that is the handle. Rarely do we clean door handles. 23% of times do we clean the door handles. So this is a diagram which is actually giving us a wake-up call, so that when our support staff are doing the cleaning, make sure that they now put some effort on these areas which you are saying are below 50%, and also increase the ones which are above 70 to at least 100%. So we have the patient education, which is also a very important component in patient and staff safety. Remember, as Jaimbo said, you can get infection from the patient, and you can also give that patient some infection. So patient education is very important. We don't want you to be close to a patient who is coughing without covering their mouths. So patient education is very important. We don't want a patient who will be touching his wound and then touching your hand. So all comes down to patient education. So educate the patient on IPC, and IPC, we always talk about the standard precautions like hand hygiene. Actually, basically, if you tell a patient to be washing their hands every time they touch a surface, that will go a long way. So let the patient channel advocacy through their IPC links. All the hospitals actually should be having what we call IPC linked persons, who should be like advocates of the patient, and they can channel the same through the patient safety department. Always educate the patient to be able to know, to be part of their caregiving. Educate patients about their conditions. Many times, a doctor examines a patient. When the patient tries to ask them, what am I suffering from? The doctor is not willing to say anything. The patient is just told, make sure you don't touch this place. No reason is given. That is not right. You educate a patient the reason why you don't want that patient to touch that particular place. So educate the patient about taking care of themselves, to protect themselves from acquiring other infections within the hospital. Then remember, there are two things. As a caregiver or recipient in this case is our patient. There are two things we both the groups, that is the caregiver and recipient of care, should understand. The two facts are the various ways infection can be transmitted and the ways the infection chain can be broken. That is the way to prevent that infection from spreading from one person to the other. I think I ended there with this year's theme of make infection control your intention. Make your intention infection control. I think that is the correct way of saying it. Thank you. Back to Dr. Kinuthia.
Thank you very much, Kibiwot and Celestine, for a well done presentation and reminding us of, very simple 10 ways that we can protect our patients. I think as I was listening to you, I just thought when you're talking of patient education and the way sometimes this can be the poor link, the weak link in ensuring infection prevention, when we do not educate our patients well on what their roles are and how they fit in helping to protect themselves and to protect others as well. So we are always reminded that we all have a role to play in enhancing patient safety during healthcare. So I'll ask that you continue typing your questions in the Q&A so that we can look at them at the end of the session. But for now, I have two wonderful persons who are in the panel today. And I will ask, starting with Dr. Okutoi, to just give a few comments around issues of patient safety, issues of infection prevention, and what we are talking about today as we continue to make more noise about Infection Prevention Week. Dr. Okutoi, please.
Thank you very much, Dr. Kinuthia, and a great presentation by Charity and by Kibiwot and Jaimbo. Indeed, they have reminded us of the essence of infection prevention and given us very practical approaches towards them. I think my comment is that IPC is that cornerstone for entry in terms of patient safety, because it is extremely important, and yet at times we may not quantify how much savings we have by just doing the correct hand hygiene practices, ensuring that our process flows enable safety to happen in terms of having structural interventions that make us prevent infections coming from patient to patient or to staff or to the furniture and the other aspects of the environment in which we work in. So I think it is very important that we, as institutions, as individuals, as those receiving care, we continue placing IPC where it belongs. The correct practices have great savings, and these savings are among the vulnerable. We know how our units can be, our newborn units coming to the critical care areas, coming to the post-surgical patients, even those in medicine, those in the burns unit. And so I think ours is to drum the beat that it is worth doing the correct practice, and yet it is not just me, but we have to have a culture change. The system has to dance to this by I taking care of my colleague and I taking care of the patient. I just wanted to give a comment on the matters of having dedicated teams that support this agenda. I think as KNH, we applaud the work that IPC team are doing. At times it is difficult for us to give care, and at the same time, we are trying to confirm that everything that we are doing is correct. So when you have a dedicated team like the IPC team, then they're able to give time for surveillance, for audits, and to have data that give us status of where we are. And as you've said, what is measured, what is not measured cannot be improved. So the dedicated team, I think, is an investment that all institutions should give, unless if there are very few, and so they give protected time for their staff to concentrate on matters IPC. And the approach is that you cannot be everywhere. And so this dedicated team working with champions is a great approach of being where the rubber meets the road. And so we applaud management for continually ensuring that the IPC is well staffed, and that also accountability structures are there to ensure that they deliver that which increases or pushes the wheel of ensuring that no patient is harmed during care by infections that are gotten in our environment. So I think allow me to stop there, but just to appreciate the systems that are supported around and about IPC and the wider group that involves all the other players, including the people from infrastructure, those from procurement, from catering, from laundry, from the clinical side, and the leaderships also from pharmacy and laboratory. So I think having that dedication and structures that communicate the data that we collect as far as we are doing on matters infection prevention and control keeps the ball moving, and it makes people accountable and to correct the small or big things they need to tackle. Thank you, Rosalie. Back to you.
Thank you so much, Dr. Kutoi, for your wonderful comments, and of course for reminding us that IPC does not work in isolation. The support from management and collaboration with other departments is very key. So thank you so much again for always supporting us and giving us that opportunity to serve and to have that all that we need to serve well. So I'll ask our next panelist, Dr. Nyukuri, just to make a few comments. And Daktari, as you're making your comments, I need you to thinking of making our intention infection prevention. What would be your, your advice or your call to fellow clinicians and fellow healthcare practitioners on how we can make our intention infection prevention? Dr. Nyukuri.
Thank you, Dr. Kinuthia. I'd like to thank the previous presenters for the wonderful presentation. Personally, I've learned a lot, and the message they have shared with us is very important in terms of making our hospitals safe. We know hospitals are a place where patients do come to be treated of their ailments, but they can also be places where infections can be acquired. I really like what the first presenter said. Hospital-acquired infections are preventable, and it is our duty and role to break that chain of infection. And that's speaking from a clinician's point of view. Looking at hospital-acquired infections, we know it's not just infections between patients, but also us as healthcare workers are at risk of acquiring these infections, and also the other visitors who are coming to the hospital. And so it's really, really important that all of us are vigilant to prevent acquiring these infections, because more often than not, they happen to be difficult to treat and requiring more expensive drugs and probably more tests to treat them. I think the second thing I'd also like to talk about is what happens when a healthcare worker feels ill, falls ill. I think one thing that we tend to do, we are in a rush to treat ourselves, grab a drug for whatever reason. And one thing we know is fever is not an indication to get an antibiotic. A sore throat is not an indication to get an antibiotic. A deranged lab panel is not an indication to get an antibiotic. An antibiotic is used to treat an infection, suspected or confirmed. And as Kibiota said, has reminded us, it must be the appropriate antibiotic given through the appropriate route for the appropriate duration of time. And so what I see happening a lot, especially when we get sore throats, going to grab azithromycin to treat the sore throat is actually wrong practice, because some of these antibiotics also have their adverse effects. These drugs, number one, select for drug-resistant microorganisms, and therefore that's why we are having this huge problem with resistant microbes. And number two, they also have other adverse events, like, for example, azithromycin. It can prolong the QT, which has effects on the heart. And if you're taking other medication, or if you have heart problems, it can actually be a deadly drug. So it's not something that we should just be rushing and popping it like the way people take paracetamol. That's why it's very important to, if you feel you need to take an antibiotic or a drug, just to have a chat with, just to have the appropriate investigations done before that drug is taken. And KNH launched recently a very good document on diagnostic stewardship, a clinician's handbook, which I'll encourage all clinicians to have a copy and go through several times, because it actually takes us through the diagnostic steps that need to be taken before you can come to a diagnosis and prescribe the correct antibiotics. One of the challenges we also know is actually even the diagnostics that are used to look for these infections are not appropriate. So my call to clinicians also is actually to go through this document, familiarize themselves with it, and it will also be very helpful in terms of fighting the hospital-acquired infections. I think I'll stop at that. If there are any questions, I'll be willing to address them. Thank you.
Thank you so much, Daktari, and of course bringing in the issue of antimicrobial stewardship, which is very key. And one of the things that you can't separate from IPC is antimicrobial stewardship and diagnostic stewardship. These three form, a triad and work together. So even as we implement these, processes in our hospitals, we need to ensure that all the three arms are working well and working together. So thank you so much. For now, we will move on to the Q&A. I'm looking at the Q&A tab to see what questions are there. I know there are very many issues about CPDs. I may not be the right person to answer this, but please kindly keep emailing the CPD, knhcpd@gmail.com. We will follow up and see if there are any issues around CPD issuance, and then that can be communicated. Again, thank you so much for those who have appreciated the presentations, that they are well done and they are good presentations. Now, about getting the copies of the presentations, this will be uploaded in the KNH YouTube channel, I think. We're actually on Facebook Live at the moment. So when you check on our social media later on, the different arms, you will find these presentations. Now, there's a question on, I think I should ask Kibiwot to answer this. Someone asked, Anne Lemalone asked, how does one handle utensils from isolation ward at home? Kibiwot, if you understand that question.
Okay. Let me attempt to answer the question. I think the first priority should be make sure you use equipment or items which are disposable. If it is cups, it is always encouraged that when you are dealing with patients with infectious diseases, use disposable cups, disposable plates, and all that. That said, if it is not possible to do that, it is always important to decontaminate all the equipment on site. Don't carry them home. Decontaminate the cups, the plates before you go home. So I'm sure in that facility, the infectious disease facility, they should be having a sodium hypochlorite ready for those items to be soaked in. After soaking, it will be safe to handle when the relative takes it home. Maybe that is the best way I can answer it. But always it is important we use just disposable. Number two, make sure you decontaminate on site. Don't carry contaminated plates back home. Thank you, Dr. Hari.
Thank you so much. So is there a way that if you find yourself with them at home, you'll be able to decontaminate? What would be your advice?
If you find yourself with such items at home, if you cannot dispose them, you can still decontaminate. If somebody has access to sodium hypochlorite, or but the best, if maybe you can use soap and water, but okay, that one is not very well recommended. But decontamination is actually the key, and if it is possible, it should be disposed.
Okay, thank you, Kibiwot. Sovina is asking that they did not get the 10th or last of the infection prevention method. I don't know which part of this you did not get, but there is it's in the first poster that we presented, 10 ways to protect your patients from APIC, Association of Professionals in Infection Control and Epidemiology. So you will see it, maybe if it can be presented, shown on the, or if we can share it as a part of the screen, so Vina can look at that. And then, of course, we'll also show it during when we're looking back at the presentation. Then the next question, I'll take this to Dr. Nyukuri. There's an issue of pediatrics sampling. So someone says, thank you for an amazing presentation. In pediatrics, sampling for culture, especially blood, requires a lot of blood, which is rarely done. What's your advice on tackling this?
Thank you. I'm not a pediatrician, so I really don't know. It's not my area of, I normally don't deal with children, but what I'll say, and this cuts across, is as much as possible, we need to obtain an appropriate sample. Because without an appropriate sample, we will not be able to know the ailment that the patient is suffering from. In pediatrics, I know we have a special culture bottle for pediatric patients that requires a smaller volume of blood as compared to what we use in adults, and it's more enriched, and probably that should help. Again, also very important, depending on where you are, to liaise with your laboratory team, and they'll also guide you in terms of what they can do with the samples that is available, basically, so that we break that disconnect between the clinicians and the lab. Sometimes we just take a sample and take it to the lab, and then the people in the lab start asking or wondering what to do with this sample, whether it's inadequate or it's the wrong sample. So if you anticipate such challenges, I think a good approach is to have a chat with the lab team first, even before you collect that sample. Thank you.
Thank you, Daktari. I totally agree that communication with the lab is very key. So the other question is, Celestine, what is the best way to disinfect dressing parts after a procedure? Celestine or Kibiwot, if you're able to.
Okay. Usually after using the BD pack or any other surgical instrument, we are supposed to make sure that all the bioburden has been removed. And the best way to do that is using the enzymatic detergent, which is available in most hospitals as an endozyme. After that, the second step is supposed to be to decontaminate the equipment, which can be done in many cases. It is usually done, step 2 is usually done in CSSD. After the decontamination, it is rinsed or cleaned. Before now, it is packed for sterilization. So that is the process. Remove the bioburden, decontaminate, rinse, then autoclave or sterilize.
So if you come to our setting at the KNH, what we do in the wards is to remove the bioburden. Then it is collected to the CSSD, where now the rest of the process is going to happen. So you remove the bioburden using the enzymatic, the way Kibot is saying. And from there, it is always taken now to the CSSD. And we had a Facebook Live today, so which was showing the steps. It is received, then they again continue the process. They do the disinfection, they do the rinsing, they do the packing, and then it is now sterilized for use, for next use.
Thank you, Celestine and Kibiwot. And I think just to add on that, apart from just thinking what is the best way, I believe as hospitals, we should have standard operating procedures on how we handle, instruments, and actually just do any activity in the hospital, so that we are not left to think what should be the best way or what should be the right way. So just to encourage the attendee who asked that, you can follow up with your hospital, what the processes are and what the standard procedures are, as we try to standardize the way things are done and to ensure that as we do this, we are also getting best results. So I will ask one more question, okay, two. Dr. Okutoi, I need you to answer the next question from a management point of view, and also, of course, as the Director HCQ. This is from Judy Machuka, and she says, thank you for the very informative presentations. Kindly shed more light on the procedure for reporting and addressing through redeployment or rotation when there is concern by a healthcare provider of being at increased risk due to overexposure of a high-risk area for a prolonged time. For example, continuous provision of counseling services in the areas. Dr. Okutoi, would you kindly shed some light on this?
I'm not sure whether I have understood it. Kindly just repeat.
So I think the question is, what should be the procedure for addressing one of the issues when Kibiwot was discussing about staff safety, I think, is to redeploy staff if there's a concern of being at increased risk or overexposure in an area.
Okay, thank you. I think we have gone through those spaces during the COVID pandemic, and we were just thinking about it today, that where we came from with a lot of stigma, now we're at a better place. But just using the presentation that was shared today, that when COVID happened, there was guidance, and the guidance that was supported by IPC was not only on how we will behave around the patient environment, but the flow of the patient within the institution, which were the red areas, which were the green, which were the orange, and just we stratified the level of risk. So it means that we start by, first of all, acknowledging that healthcare environment is hazardous, but there are places where the hazard is higher than others. That is why the burns unit has specific restrictions. So it's not only for the patients, but also for the staff, depending on whether we are talking about laboratory, the chambers where we are doing TB cultures, or we are doing chemo, medication mixing. So I think the institution is supposed to take care of the staff and to ensure that they are not endangered, courtesy of the kind of work they do. And so all mechanisms should be put in place to enable them to have care provision in a safe way, so that it's not only about provision of PPEs, but even having infrastructural changes. We didn't used to have the booths and the chambers to work in the lab many years ago, but now, I don't know why I'm having a lot of echo. Yeah, so but now things have changed. So it is an OSHA approach, but it starts by doing a risk stratification. We know that the healthcare environment is hazardous, but we determine which areas need interventions that are different, and that is already known. And in those areas, we give them the PPEs plus the other infrastructural changes that needs to be done. But however, on a day-to-day occurrence, I don't think we can redeploy a staff from a high-risk area to bring another staff to that high-risk area. I think we need to manage that risk, either by reducing the time of exposure or reducing the the number of hours they are exposed to that place, or just having an approach that will ensure that there is a protection. So each area, I think, needs to come to a way of addressing the area in a more specific way. So if Judy had a specific scenario, there would be guidance. By the way, in Kenya, we have something called minimum standards. Yeah, before a healthcare institution is opened or licensed, or before you get a level of like radiology, before you're able to have a CT scan or MRI, there are specific requirements even for infrastructure, and those ones are to prevent the exposure. And so similarly, when it comes to IPC, these are things that happen all the time. Spills happen, blood happens in theater, there are splashes. And so we need to have guidance when that happens. What is the staff supposed to do for their protection? How do we protect the patient? So it is a mix of having policies, but at the same time implementing the structural changes to minimize the risk. And then also as an institution, and I think this has come from the Ministry of Labor, we have registers that is supposed to track the occurrence of this. This is done very well in the manual industry, in building and construction, but in health, we do not document enough. So we need to be also document as frontline healthcare workers when these things happen, because there are some, they are not alarming, but in the long run, we will say we have had TB in a certain ward, this number of staff. Is it possible that are being exposed from the patients? So I think it is a mix of us reporting immediately and taking interventions, but also having mechanisms that inform management of the trends. And that's why we are also tracking matters of COVID amongst the staff, whether the exposure happened at home or in the hospital. It would be good to know the number of healthcare workers who are who get infected, and then also the consequence to their families. So thank you for the question. That was just an attempt, both at individual staff level, to the system level, and to the learning health systems. Thank you.
Thank you, Dr. Oktoi. I believe you've covered it very well. There is always a starting point, and these issues can be discussed. So I know our time is almost done, and I want to ask the final question to Charity. So Charity, you did a very good job of introducing to us patient safety. And we've talked a lot about how, what the healthcare workers should be doing. So what would you, in summary, what would you say is your role for the patient in ensuring safety during healthcare?
Thank you so much, Dr. Kinuthia. Our role as a patient safety officer is to ensure that the care offered to patients is safe. And when patients come into the hospital, they live better. They don't carry any infections. They don't get any harm. And what they get is quality, safe care from our institution or during the healthcare treatments. So generally, we monitor, we do surveillance for any safe occurrences, try to learn from them, instill a culture of safety whereby if the system fails us, we pick it up, we learn, and try to put preventive measures by communicating back to the service providers so that we're able to improve. I don't know if I've been able to tackle the question, but
Thank you, Charity. I think you've covered it, that there needs to be that communication and reporting back, and of course, understanding what's being done to you as a patient. That is very key. So we have exactly 4 minutes to end our time. So I will allow each of my presenters and the panelists half a minute each. Starting with Charity, now that you're already talking, please give your final parting shot.
I would like to request that we keep ourselves safe, we keep the patient safe, and we took all precautions to act to ensure that we give quality, safe care to our patients. Thank you.
Thank you, Charity. Celestine?
Thank you, everyone, those who have attended. My parting shot goes with the theme for this year, Infection Prevention Week. Make your intention infection prevention. In whatever you're doing in the hospital, can we make this our intention? Consciously, very consciously, that whatever it is that I want to do today, whether it is in the hospital or in the community, I am making my intention infection prevention. Thank you.
Thank you very much, Celestine. Christopher?
So for me, thank you very much for the participants who made time to attend this webinar. My parting shot is, when you are in a hospital, standard precaution is always the key, because at the hospital is a place where you can easily transmit or get infection. A standard precaution does not call for irrational thinking. It is simple, informed, and rational thinking, so that you are able to use the correct PPE at the correct time. That is my parting shot. Thank you, Dr.
Perfect. Thank you so much. Dr. Nyukuri?
I'd like to thank all participants and also the presenters. My parting shot is infection prevention control is a collaborative effort, and all of us have a role to play in it. And we should always strive to gain more knowledge, more skills on infection prevention, and attending this webinar is actually a step in the right direction. Thank you.
Thank you so much, Dr. Dr. Okutoi?
Yeah, mine is just to appreciate the opportunity to be part of this advocacy webinar. We drummed the beats for IPC, and my parting shot is that let us continue observing hand hygiene. Let us be advocates for it. Let us ensure that there's water flowing, that there is soap, there is a hand towel, there's some sanitizer, and let us be the one who converts those inputs into a correct process, and indeed we will have a reduction in the hospital-acquired infection. We will contribute to the wider good, having care that is a better, cheaper, and reduce hospital stay. And you could just also be saving a life. Let us wash our hands. Thank you.
Thank you so much. Those were wonderful parting shots. They've driven the point home. So I want to thank you so much once again. Dr. Rosalind Kinuthia, I was your host for the day. And for me, it's just to keep drumming the theme for the week, that we make our intention infection prevention, and preach this message to all. Let's be our brother's keeper in terms of ensuring that we are keeping patients safe from infection, as this is our responsibility for all of us. So thank you very much, and thank you to our KNH research team for hosting us today. Have a lovely evening, and see you next time. Bye-bye.
Bye, thank you.